took another recording. And now we're seeing this scheme. If I play the movies, once again, we're seeing contact on the anterior implant abutment. There is light contact on the posterior implant abutment, but as I play it forward again, look at the significant contact on these two implants without contact or without primary contact on the natural teeth. And that is after I've adjusted the implants. As I play it forward, finally we get contact on natural teeth. But in fact, it's delayed. The natural teeth are contacting after the implant. So we make another adjustment. The adjustments result in this occlusal scheme where you start to see now more contact on the cuspid, contact on the natural crown of the first bicuspid, but still contact on the implants. I believe that we should have contact on the implants, otherwise they're non-functional and high-priced space maintainers. So I want contact. I just want delayed contact on the implants, allowing for depression of these natural teeth into their socket. So as I play forward, notice that the primary force is anterior to the implants now. It is opposing the first bicuspid and opposing the central incisor. We do have some contact on the anterior abutment, but the higher, earliest force is anterior to the implants. As we play it forward, 0.02 of a second later, we can see that our most significant contact is in advance of the implants themselves. We continue to play forward, and now the force is being generated, and finally, force comes onto the implant, the terminal implant, the anterior implant, but force had previously been generated in the anterior teeth, allowing these anterior teeth to depress and the contact to occur. All of this, as you see, occurs within just over 0.1 of a second. So we're very specific in our timing, and I challenge anybody to tell me if there's an articulating paper out there that allows me to differentiate a 0.1 of a second difference between these contacts here and these contacts here. The resultant situation is this, that we were able to regrow the bone through precision equilibration. We were able to take the environment from a 4-thread loss, only doing precision equilibration, allowing that bone to regrow. We increased the amount of contact on the bicuspid here by allowing that to contact first, delaying contact here, but truly having contact there. So these are functional, but functional at an appropriate time that not only allows for a healthy crest, but in this case, regenerated lost crestal bone. The value to this individual was incredible because we were considering sectioning off this unit, removing this implant, allowing it to heal and replace. The value to this individual was incredible. And we were able to do this only because we had precise equilibration methods available to us. Now, speaking of some precise equilibration, I would ask you to guess which contact, if the patient says the upper left is high. Which contact would you address? My answer was, I don't know. I should address lingual slopes of the lingual cusp first and lingual slopes of the buccal cusp second and buccal slopes of the lingual cusps third. But when I play this back, I noticed that, in fact, the patient's right side is the side that started to hit first, even though they felt the left side contact first. Which is interesting, isn't it? Because if the patient says the left side's contacting first, we're going to go to the left. And if the patient says the right side's contacting first, we're going to the right. Which means the patient, the one that knows the least about dental care, is driving the direction of the care, which to me wasn't reassuring. What I found out when I played this just about 300 seconds later was that we had primary contact on tooth 11 and in the 14-15 area. And we can see that by the red column here on the distal of the 11 and on the marginal ridge of the 14 and 15. And I ask you, how many of you looked at that contact on the distal of number 11 as a source of a problem? But yet, if that contact is high and early, you can imagine that the entry of the mandible into the maxilla, hitting on that cuspid, will break that veneer. That's the issue that we can address because we have precise equilibration techniques. And finally then, more contact occurred. You can see that the bicuspid picked up, more of the 15 picked up, more of the 14. But the 11, that small mark, was a primary contact. So through this instrument, we can depict which contacts have more force and which contacts, out of all these contacts, appear first. That's the true prematurity. When we apply it to the implants, we can delay the contact on the implant until the natural teeth have first contacted.